I'm Dr. Archana Budhathoki. I'm currently working as consultant ophthalmologist. Students often find ophthalmology as a difficult subject during examination preparation. So today I'll be discussing about past recall common entrance examination question. So let's begin with our first question. In soft contact lens users, which organism is most commonly associated with an increased risk of infection? I'll be discussing about each option separately. So the first option is Acanthamoeba. So what is Acanthamoeba? We know it is a living protozoa which is isolated from public water supplies, hot water tube, baths, swimming pools, and even mineral waters. So Acanthamoeba is a protozoa and it is often frequently associated with contact lens users. Why contact lens users? Because contact lens users tend to use the contact lens solution, and in this contact lens solution they can be contaminated, or even in cases of non-contact lens users they can be the water ponds, swimming pools, so they can cause the Acanthamoeba keratitis. So in the question there is increased risk of infection. What kind of infection? The infection will obviously affect the cornea. So if it affects the cornea, then it is termed as keratitis. So any term keratoconus, keratitis, it means cornea, and itis means inflammation, right? Itis, inflammation. So Acanthamoeba keratitis has a distinct sign than other keratitis. Let's see how it differs. So it differs from the ring infiltrate. We can see there is a ring infiltrate, and common sign is ring infiltrate in case of contact lens users. And another common symptoms is patient present with severe pain. Severe pain. Why severe pain? Severe pain because there will be the perineural invasion. So if patient presents with contact lens use and there is the severe pain and there is the ring infiltrate, then we should suspect about Acanthamoeba keratitis. Now Pseudomonas. What is Pseudomonas? It is strictly aerobic organism and it appears to be dependent on iron for its growth, and changes in iron metabolism it affect its virulence, and changes in iron metabolism changes its virulence with respect to the corneal infection. So why the Pseudomonas I'm emphasizing? Because Pseudomonas causes keratitis which is rapidly spreading. And why rapidly spreading? Because it produces toxin A. It produces toxin A which breaks the protein due to the numerous proteases enzyme. It enables at epithelium pass quickly. So due to its protein mechanism, lipases, esterases, enzyme activities, it spreads very rapidly and it extends periphery and deep within 24 hours. So within 36 hours, there will be stromal necrosis. And why it is very important? Because it can lead to severe vision loss. Okay, it can lead to severe vision loss, and it spreads concentrically. As you can see, the ulcer spreads concentrically and symmetrically. There is symmetrical and concentrical ulcer which forms the ring ulcer. Again, it forms the ring ulcer. And as we can see here, there is hypopyon. What is this? Hypopyon. So what is hypopyon? Pus in anterior chamber. Pus in anterior chamber is known as hypopyon. So if the patient presents with the ulcer that spreads very rapidly, very frequently within 24 hours, they develop the ulcer which is spreading concentrically, symmetrically, then we should suspect about Pseudomonas infection. Moving on to the third option, staphylococcal. Staphylococcus is very common in our normal flora. It resides in our normal flora. There are two types of Staphylococcus most commonly residing in our normal flora, that is Staphylococcus epidermidis, Staphylococcus aureus. And how it presents? It presents as central oval opaque with distinct margin. As we can see in this picture, the ulcer is central oval opaque with the distinct margins, and it can be associated with mild edema or the abscesses. So, coming to our question, was associated with an increased risk of infection. So, with increased risk of infection, which organism is associated? Pseudomonas. Because as we already studied, Pseudomonas is associated with the spread. It is rapidly spreading due to numerous enzymes, rapidly spreading, and it is often aggravated. Predisposing factors are corneal trauma, vitamin A deficiency, immune suppression, and about Neisseria gonorrhoeae, it causes ophthalmia neonatum, which we will be discussing in further question. So another important question which can be asked in common organism about the common organism is, which organisms can invade the intact epithelium? So this question is frequently asked in common entrance examination. So which are the organisms? For easy remembrance, we can use the mnemonic channels. We are seeing the channels every day, right? So what is the mnemonic and organism? C for Corynebacterium diphtheriae. So C for Corynebacterium, HA for Haemophilus influenzae, and E for Neisseria gonorrhoeae, as you can see in this option. L for Listeria monocytogenes, Listeria, and S for Shigella. So this is another important question. So you can always remember channels. Which of the following organism is associated with higher risk of complications in an ophthalmia neonatum? So before moving on to the option, let us understand what is ophthalmia neonatum. As we can see in this, or ophthalmia means eye, neonatum means neonate. So who are neonates? First 28 days of life, children of first 28 days, they are neonates. So ophthalmia neonatum means those in which there is hyperacute purulent conjunctivitis occurring in the first 10 days of life. Usually it is caused by gonococci. The time of onset in ophthalmia neonatum provides an important clue to its etiology. So if it occurs in 24 hours, then the usually causative etiology is due to chemical. If it occurs during 3 to 4 days, then it is due to gonococcal infection. If it occurs within 1 week, then it can be caused by chlamydia trachomatis. And if it occurs later in life, that is during 2 weeks, then it is caused by herpes simplex virus. So now talking about other options in this question. First option is chlamydia trachomatis. Let us see what chlamydia trachomatis can cause. Chlamydia trachomatis have several serotypes which can cause different diseases. So these serotypes are based on direct immunofluorescence test, and serotypes E, B, C, it causes trachoma. Serotypes D to K, it causes inclusion conjunctivitis, that is chlamydia trachomatis conjunctivitis, and serotypes L1 to L3, it causes lymphogranuloma venereum. So for us, according to the inclusion conjunctivitis, we will be discussing about this. So let us understand how the neonatal inclusion conjunctivitis differ from that adult version. So in the neonatal conjunctivitis, membrane formation occurs. Amount of mucopurulent discharge is much less in adult disease. In adult disease, the conjunctival reaction is follicular, not papillary. So in this picture, we can see there is a severe case of chlamydia ophthalmia neonatum with copious discharge. There is a discharge here, and there is the membrane formation. and there is the pseudomembrane formation. There is also the papillary conjunctival reaction. So this is the picture showing the Neisseria gonorrhea conjunctivitis. Neisseria gonorrhea conjunctivitis. So Neisseria gonorrhea conjunctivitis, what can we see? There is a profuse discharge. There is a profuse whitish discharge. The eyelids are matted. The eyelids are matted. So the Demaris retractor is used here to open the eye, and in the eye we can see profuse discharge, whitish discharge. The eyelids are swollen. So eyelids are swollen and there is chemosis. So this is the case of severe Neisseria gonorrhea conjunctivitis. This is the case of neonate. And this is the case where there is peripheral corneal ulceration and perforation which occurs after the onset of the hyperacute conjunctivitis. We can see the congestion here, perforation. So Neisseria gonorrhea is associated with the complications such as corneal perforation, which will lead to the severe visual loss in the patient. So in our question, chlamydia trachomatis, Neisseria gonorrhea, herpes simplex, all these three options can cause ophthalmia neonatum, right? Because we saw according to the etiology, gonococcus, chlamydia, herpes simplex. But what is the question? It is associated with higher risk of complications. So higher risk of complications, which organism is associated with higher risk of complications? Yes, Neisseria gonorrhea. Why Neisseria gonorrhea? As we saw, it was associated with copious discharge. There was very much corneal involvement, that is corneal ulcer, marginal ulcer. There was perforation, and even later in life it can cause iritis, iridocyclitis. It can even cause gonorrhea, can even cause septicemia, endocarditis. So these are the complications. So with higher risk of complications, Neisseria gonorrhea is associated. So the answer is Neisseria gonorrhea. Okay, let's move on to the third question. Okay, this is the case scenario. Patient complains of pain in movement of eye and there is blurriness of vision on the left eye. On examination, visual acuity is found to be 6.6 on right eye. So on the right eye, it is normal, and 660 on the left eye. In addition, there is hyperemia of the disc and there is centrocecal scotoma. What is the most probable diagnosis in this case? Okay, let's start with each option. Conjunctivitis, papilledema, optic neuritis, pseudotumor cerebri. Okay, conjunctivitis. So what is conjunctivitis? Conjunctivitis is inflammation of conjunctiva. So how it is presented in our OPD day-to-day life? Patient presents with redness, swelling, congestion, discharge, itching. So it depends on the etiology of the conjunctivitis. If it is bacterial, then patient presents with discharge. We can see sticky eyelashes, congestion. If the etiology is viral, then symptoms are more than the signs. And if it is allergic, then patient presents with itching. And we can see on slit lamp examination, papillae. So is there blurring of vision and conjunctivitis? No. So we can exclude this option, right? We can exclude. So this is not the option. This is not our option. So moving on to the second question, second option, papilledema. So what is papilledema? Papil. What do you mean by papil? Optic disc or optic nerve head. And edema means swelling. So swelling of the optic disc or optic nerve head is known as papilledema. So in the papilledema, patient can present with visual acuity 6/6, but it is never ever decreased to the rate of 60 vision. Okay, and there is blurring of the disc margin. Okay, so this is the case of papilledema. There is the blurring of the disc margin, and it is due to the increased intracranial pressure. There is secondary to increased intracranial pressure. There will be no visual defect because there is secondary cause, that is increased intracranial pressure, and visual acuity is usually normal. There will be enlarged blind spot. Enlarged blind spot. What is enlarged blind spot? In the visual field where we see optic disc, then it is known as blind spot. So this is the blind spot, right? This is the blind spot. So we can exclude this option too. Why we can exclude this option? Because vision is 660. So there is unilateral loss of vision, right? But in papilledema, there will be no loss of vision and there is hyperemia of the disc. But in papilledema, there are obvious phases of papilledema, but it is generally associated with blurriness of the disc. And centrocecal scotoma, no, it is enlarged blind spot. In visual field, it is associated with enlarged blind spot. We can exclude this option too. And about the optic neuritis, what is optic neuritis? Optic nerve inflammation. Itis means inflammation, and this is the inflammation of optic nerve. So how it presents? It presents with generally unilateral. Usually it is unilateral. So there is unilateral loss of vision. So it also presents with unilateral visual loss. It is sordid. And optic neuritis generally is associated with pain on eye movement. Why pain on eye movement? Because as we know, eye is a pyramidal structure and there is the annulus of gene and the optic nerve. Optic nerve, it inserts into the sclera lamina cribrosa, and the extraocular muscle, it also inserts into the sclera. So the superior rectus and medial rectus muscle, which are very much close to the optic nerve, their inflammation of the optic nerve, it causes the inflammation of the muscles, so it causes the pain in movement of the eye. So pain in eye movement is the feature of optic neuritis. And another feature which presents with the optic neuritis is color vision defect. Color vision is abnormal and it can present with, as we know, afferent nerve is optic nerve, so it can present with RAPD. What is RAPD? Relative afferent pupillary defect. And the disc looks like this. As we know, optic neuritis, there are three types of optic neuritis, that is papillitis, retrobulbar neuritis, and neuroretinitis. So papillitis means optic nerve, optic disc, right? Retrobulbar means behind the eye, behind the eyeball, and neuroretinitis means involving the surrounding retina. Optic nerve plus surrounding retina. Surrounding retina. So in case of papillitis, it presents with hyperemia of the disc. So we can see there is the hyperemia of the disc, and it can be also associated with the hemorrhages, and RAPD is present. And in the visual field, we can see the centrocecal scotoma. So what is centrocecal scotoma? Centrocecal scotoma. Scotoma means not to not see, and central means central, and cecal means surrounding. So this scotoma, central and surrounding the optic nerve, it is centrocecal scotoma. So this is the centrocecal scotoma. So centrocecal defects are seen in optic neuritis. And what is pseudotumor cerebri? It is also known as idiopathic intracranial hypertension. Intracranial hypertension. So it is more common in female obese patients. They present with blurring of the disc margin. So let us move on to our Question: there is pain in movement of eye, blurriness of vision on the left eye, that is 660 on the left eye, hyperemia of the disc, centrocecal scotoma. So all these points are in favor of optic neuritis. So our answer is optic neuritis. Pseudotumor cerebri we can exclude because here the patient does not present with the intracranial hypertension raised ICT signs, so we can exclude this option too. Okay, let us move on to our next question. Here is again the clinical case scenario. Patient presents with redness of the eye and sudden painful loss of vision. On examination, there is ciliary congestion and pupil is vertically oval and mid-dilated. Which investigation is performed to reach the diagnosis? So before reaching into the investigation, we have to know what is this case. Here, the important clue is sudden painful loss of vision. So if there is sudden painful loss of vision, what comes in your mind? So right, angle closure glaucoma. One very important differential diagnosis would be angle closure glaucoma. And there is acute iridocyclitis, and there will be chemical injury to the eye or mechanical injury to the eye. And another part is there is ciliary congestion and pupil is vertically oval and mid dilated. This one is very important point. That is pupil is vertically oval, as in this picture there is pupil is vertically oval and this is mid dilated. So what is the normal size of the pupil? It is 2 to 3 millimeter. And what is mid dilated? It should be around 5 mm or 5 to 6 mm. Let's say 5 mm mid dilated. Which investigation? Okay, let's discuss about the investigation later. First of all, what is this case? This is angle closure glaucoma, right? So why the primary? So angle closure glaucoma is primary and secondary, right? So primary angle closure glaucoma can be again divided into total and partial. So how the attack comes? Why there is mid dilatation of pupil? It is due to the attack of angle closure. But what is this? Let us understand this. So how the attack comes? So there is the cornea, and behind the cornea there is the iris, right? And from the iris there is the ciliary body, and in the ciliary, after the ciliary body there is a lens. Okay, so aqueous humor is secreted from ciliary body, right? And aqueous humor goes from posterior chamber to anterior chamber. So what is anterior chamber? What is posterior chamber? We are clear. Iris divides into the anterior chamber and posterior chamber. So iris, this is the iris. Beyond the iris, there is anterior chamber. This is the anterior chamber. This is the posterior chamber. So lens and the iris, it iris divides into the posterior chamber and anterior chamber. The aqueous flows from posterior chamber into the anterior chamber. So this is the aqueous. This is the normal. But when there is the angle closure, so what angle? Iridocorneal angle. When there is the angle closure, this was the normal, but when the iridocorneal angle closes like this, there is the cornea, here is the lens, and here is the angle, iris, and all. So what will happen? There is no angle from where the aqueous will drain. It can't be drained, so aqueous will accumulate, and it will cause iridolenticular apposition. Lenticular apposition. There is the mid-dilated pupil and vertical oval is due to the ischemia of the sphincter pupillae. We know sphincter pupillae causes the constriction of our eye pupil. So constriction of the pupil, it causes the not to dilate. That is, if the sphincter muscle does not contract, there is ischemia, then pupil remains mid dilated. Okay. So now we know this is the case of angle closure glaucoma. Which is the investigation you like to do? Now, as we know, aqueous humor is accumulated here, so we should see for intraocular pressure. So what is intraocular pressure? normal intraocular pressure is normally 11 to 21, right? 11 to 21 millimeter of mercury. This is the normal intraocular pressure. So to see intraocular pressure, which is the test you would like to do, tonometry. So tonometry are of two types. You know, tonometry are of two types. We'll be discussing it. So this is the CEO's tonometer. CEO's, and this is most commonly used. At first, we use CEO's tonometer, and it depends on the scleral rigidity for its measurement. And another test is Goldman applanation tonometer. This is also known as GAT, Goldman applanation tonometer. So this is the most accurate. This is most common, frequently used, and this is most accurate. Okay. And what is the principle? GAT is used in the principle of. This is also one important question. The principle is Imbert-Fick law. Imbert-Fick law. This is the principle. What is Imbert-Fick law? That is, we can see this is the indentation. That is, we are indenting cornea. We are touching the cornea. We are contacting the cornea, indenting the cornea. So we are applying the pressure. So pressure is equal to force by area. So this is the force, and this is the cornea, which is the area. Sorry. So this is the cornea, which is the area applanated. So this area will be 3.06 millimeter. Okay, 3.6 millimeters. So this force by area is the pressure. So the force is variable forces. We apply the variable forces. So the answer would be tonometer. Let us see other option. What is keratometry? Metry means to study. Kerato means cornea. So it is the study of corneal curvature. Pachymetry. So pachy means thickness, and metry means again to study. So pachymetry means to measure the corneal thickness. Retinoscopy. What is retinoscopy? Yes, retinoscopy is used to determine the refractive error. So it is not aesthetic, or this is not the option. So we can exclude all this option, and tonometry is our answer. Let's move on to the next question. Okay. Central part of the retina, fovea, largely consists of. Let's just understand what fovea is. So this is the diagram showing the normal fundus. So this is the optic disc. Optic disc lies nasal. So this is the nasal, and this is the basals, and 2 discs diameter to the temporal to the optic disc there lies macula. How do you differentiate the macula? Because there are no blood vessels in it. You can see there are blood vessels around the optic disc and in the periphery, but there is no blood vessels in the center, that is in the macula. And fovea centralis, and around the macula, it is responsible for the central vision. If patient has problem in the macula or in the central part, then it is responsible for central vision, and patient will have severe loss of vision. So in the center, there are responsible for, it is responsible for central vision. So in our option, cones. So what is cone? Cones are responsible for central vision. So C for C, and it is also responsible for color vision. So C, you can easily remember. So in fovea, cones are evidently present. This we just know that it is responsible for central vision, and fovea centralis is very rich in cones, but rods are absent in fovea. Okay, rods are absent, but in peripheral part, rods are present. Rods are responsible for peripheral vision, and rods are present in the periphery. Okay. So as the name suggests, cones are cone shaped. It is like cone shaped rods, and cones differ in the shape as the name suggests. This is the cone and this is the rod. Rods are flat. So this is the rod, okay? This is the spiral and this is the rod. So this is rod, this is cone, it is rod shaped, it is cone shaped, and rods are how much? 100 million in number, and cones are 5 million in number. And rods are responsible for peripheral vision or black and white vision, whereas cones are responsible for color vision, and they are present in the center, that is the fovea. That is the central part of the retina. That is, this is the fovea. Okay, next question. Moving on to the next question. There is a clinical scenario. 20 years old female presents to you with headache and recurrent transient loss of vision. Most common cause of this is. Okay, before moving on to our option, let us understand what is this transient loss of vision. Recurrent transient loss of vision. What is transient loss of vision? So transient loss of vision is the sudden loss of visual function in one or another eye, and they regain back to the normal visual acuity within 24 hours. Okay, so the cause of transient visual loss is, if it is less than 50 years, then migraine or vasospasm is the likely cause. This is very important. Age group less than 50 year, migraine or vasospasm. If more than 50 years, then cerebrovascular disease or giant cell arteritis should be considered. In our question, it was 20 years old female. So it can be either migraine or it can be the vasospasm can be the cause. Okay, so we can see other options: giant cell arteritis, dissociative disorders, pseudotumor cerebri. So let us see what is giant cell arteritis. So we know giant cell arteritis means patient presents with simultaneous headaches, jaw claudication, tinnitus, scalp tenderness, and there will be so much tenderness that they won't be able to comb their hair, and they are also associated with the anorexia, weight loss, fever. So there will be the Clemcept hemorrhages in the disc. There will be pale, swollen disc at times. Okay, and in the giant cell arteritis, we take the temporal artery biopsy. So we have to take the temporal artery biopsy to confirm the diagnosis. And in giant cell arteritis, ESR CRP is raised. So we should do all the complete blood count examinations and diagnose the giant cell arteritis, as it is the threatening, visual threatening, and even the life threatening condition of the patient. Okay, so migraine, about the options we have already discussed about the giant cell arteritis and migraine. Okay, let us see about the migraine. So in the migraine, it can be with visual aura or without visual aura. If there is visual aura, then there will be visual loss or disturbances for 10 to 15 minutes. There may be family history and there will be general unilateral headache. It can be aggravated by cheese, wine, or even the sounds. So there will be scintillating scotomas, and there can also be the migraine without the visual aura, okay, or without the headache too. So generally, migraine occurs in less than 40 years of age group, and migraine is also associated with the hemianopic defect. Okay, hemianopic defect, and in this video we can see the scotoma. In the migraine patient, they see the scotoma. This is the scotoma they are saying, and it enlarges over the several minutes, and after some times it will again decrease in size. After several minutes, it enlarges. As we can see, the scotoma is being enlarged. It was small in size. Now it is enlarging. So it can also be associated with the homonymous hemianopia. What is hemianopia? Hemi means half. and it can be associated with the visual field defects. Okay, so this is scotoma enlarges over several minutes. So we saw the cases. So this headache, weight loss, fever, malaise, jaw claudication, and scalp tenderness are associated with giant cell arthritis. If there is persistent headaches and pulsatile tinnitus, then there might be increased intracranial pressure and positive visual phenomena and headache accompanying binocular transient visual loss. It is migraine. So transient visual loss can also be associated with the term amaurosis fugax. So amaurosis fugax, if you see, it is also the transient visual loss, but it is of embolic origin. Okay, if there is any emboli, then it is associated with the amaurosis fugax. So what is pseudotumor cerebri? As we have already discussed, it is idiopathic intracranial hypertension. So this is not the scenario of pseudotumor cerebri because headache is tinnitus, headache, pulsatile headache. It will be pulsatile headache. So here the answer would be migraine. Okay, let us move on to our last question. That is also the case scenario. Patient presented after road traffic accident. RTA shows loss of accommodation reflex. On detailed neurological examination, what is the most likely type of lesion to cause loss of accommodation reflex? So let us understand the question first. They are saying accommodation reflex is absent. And where is the lesion? Okay, most likely type of lesion to cause loss of accommodation reflex. So here are the option. Okay, before heading into the option, let us understand what is accommodation reflex and the pathway of the accommodation reflex. So this is the accommodation reflex pathway. As we all know, the pathway always consists of afferent and efferent pathway. So the afferent starts from the retina. So the afferent nerves, optic nerve, optic chiasma, optic tract, then it goes to the optic radiation, and from the optic radiation it goes to the lateral geniculate body, and from lateral geniculate body it goes to the area number 19 where it relays its fibers, then it goes to the pontine center and it goes to the Edinger-Weisfeld nucleus. From here it goes to the both sides of the Edinger-Weisfeld nucleus. This is the bilateral pathway, so it goes to the both the sides of the Edinger-Weisfeld nucleus, and from here the efferent fibers start. So the afferent is up to here. And Edinger-Weisfeld nucleus, as we know, in the Edinger-Weisfeld nucleus, it consists of upper and lower fibers. So Edinger-Weisfeld nucleus consists of upper fibers and lower fibers. In the upper fibers, they constricts the pupil. Upper fibers pupil, constricts the pupil, and lower fibers. In the lower fibers, it gives rise to the ciliaris, giving to the ciliaris, and also the constrictor pupillae. Constrictor pupillae. So here the Edinger-Weisfeld nucleus, from the Edinger-Weisfeld nucleus, afferent nerve goes to the oculomotor nerve, third nerve, and from the third nerve it goes to the ciliary ganglion and accessory ciliary ganglion. From the ciliary ganglion it relays its postganglionic fiber, as it is the ganglion is preganglionic and this is the postganglionic. So the postganglion fibers release into the constrictor pupillae and it helps in the stimulate in response to near. So we should understand that pathway for constriction to light and pathway for constriction to near reflex is different. And in accommodation reflex, we are talking about the near reflex. In the pupillary pathway, this is the same pathway, but instead of this fibers relaying into area number 19 from the lateral geniculate body, instead of the relaying into the area number 19 and pontine center in pupillary light reflex, It will relay its fiber in the pretectal nucleus. Pretectal nucleus, okay? So, we should understand that pathway for constriction to light. Constriction to light, that is pupillary pathway, pupillary light reflex pathway, and pathway of near reflex are two different things. What they differ in? This is two different things, okay? Two different things. What they differ? In the accommodation reflex, that is in near reflex, as we discussed, this is the pathway. It will lay in area number 19, Pontine center, and from there they will go to the Edinger-Weisfeld nucleus. And in the light reflex, everything is same except lateral geniculate body goes to the pretectal nucleus, and from pretectal nucleus it goes to Edinger-Weisfeld nucleus. As we discussed, the Edinger-Weisfeld nucleus has two fibers, upper fiber and lower fibers. So, the lower part of Edinger-Weisfeld nucleus constricts on near response. The upper fiber, it can stimulate the constriction of the pupil. Okay, so this pretectal nucleus, it will stimulate the lower part of Edinger-Weisfeld nucleus, and it helps in the constriction of pupil in near response. Okay, so are we clear up to this? Okay. Now, to understand the option first, supracervical ganglion, let us understand what it involves, the pathway. So, the supracervical ganglion, it is involved in this pathway. This is pupillary dilatation pathway. How the pupil dilates? Let us understand this. Okay, from the hypothalamus, which is the first order neuron, the fibers pass through the ciliospinal center of buzz and it released in the CET1, T2 vertebra. Then the fibers pass through the cervical ganglion, that is inferior, medial, and superior cervical ganglion. It passes through all the three cervical ganglion and it goes to the internal carotid artery. Okay, internal carotid artery, and from the internal carotid artery it goes to the nasociliary nerve, and from the nasociliary nerve it goes to ciliary ganglion and to the long ciliary nerve. This is the third order neuron. So superior cervical ganglion, it is involved in the pupillary dilatation pathway. So if there is a pupillary dilatation pathway, there is the lesion in the superior cervical ganglion, pupil won't dilate. So pupil will become constrict. So this is present in what? Horner's syndrome. Horner's syndrome. What happens? Meiosis. Meiosis occurs. Okay, meiosis. Horner's syndrome, meiosis occurs. Here the question is loss of accommodation reflex means constriction absent. Okay, constriction not happening, constriction absent. So is this the option right one? No, because we are getting the constricted pupil. So this is the wrong. Stellate ganglion. What is stellate ganglion? Stellate ganglion is involved in the C6, C7 vertebra and T1 vertebra, but we are not getting this stellate ganglion in this case. In this RTA, we are not having any refracture, so we can exclude this option. Pretectal nucleus. So about these two, I made it clear in this picture that pathway of constriction to light was pretectal and pathway of near reflex was Edinger-Weisfeld. So we are talking about the Edinger-Weisfeld. So this is our correct option. Okay, I hope you enjoyed my lecture. Thank you very much for sticking to the last part. Thank you.